Thank you, Dr. Gottlieb. Okay, so to get us started, I'm going to spend a little bit of time of providing an overview of how we got to this point, to kind of fill you in, and then hopefully at the end of my talk it'll be clear to you who's here and why we're here. I'm going to walk through what exactly is the impetus, what drove us to convene this meeting today, and why did we invite the people we invited. We're going to walk through a little bit of logistics of how this is going to work. This is a little bit different than some of our other public meetings. And then what do we see as the output? Where do we want to go next? So what's the impetus for today's meeting? Well, I'll show you the slides. You've seen this before. These are the numbers of prescriptions, and the scale here is in hundreds of millions of opioids. You can see that the IRLA opioids, which are the green line, is rather steady. And the good news is, I guess, that the red line, the IR opioids, are beginning to come down. Of course, we don't know whether that's coming down, whether that represents a decrease of appropriate or inappropriate use, but still means that there's less opioid out there, but we still have a long way to go. And of course, this is the CDC slide that I know you've all seen, where the deaths continue. So we still have a lot of work to do. So just a little over a year ago, our previous commissioner announced an action plan. And one of the pieces of that action plan was to encourage the development of what was called abuse deterrent formulations, and to see if this could be not a complete solution, but clearly a piece of many different efforts to combat this. We issued a guidance in April of 2015. Guidances are not binding, but they represent our best thinking to guide industry in how to develop these products, what kinds of testing should be done both before and after approval. So just to take a second, Dr. Gottlieb alluded to this, but I just want to be clear on the terminology. I think there is a little bit of confusion about what an abuse deterrent formulation actually is. They are not abuse proof. They can be defeated, they can be abused. The idea is to just deter that. To some extent. They're designed specifically to deter specific routes of abuse, and if you read the labeling for these products, it clearly says that, whether it's to deter snorting or to deter injecting. The idea being it's going to make it more difficult for folks who might be inclined to try to crush up tablets into a powder that's suitable for snorting, or a powder that is suitable for dissolving in a liquid and then injecting. So these products at this point have these properties that we are designed to deter abuse. They're expected to deter abuse, and they have met the bar that is set by particular pre-market studies, both in vitro and human abuse potential studies. Now, just for brevity today, because otherwise I would have had a mutiny on my hands by all of our speakers, we're going to refer to them as ADFs. That's the shorthand, abuse deterrent formulation. But I just want to understand, these have not been shown in the real world to defeat abuse or to deter abuse. So just to note that that is just for convenience. So here are the products that have been labeled. There are 10 currently. 9 of them are extended release formulations, and 1 is an immediate release formulation. And again, all of these products have completed pre-market assessments, and they all have post-marketing required, or PMR, studies that they must do. The companies must complete these studies to determine how these products perform in the real world. So just to zoom in on the what's been the uptake of these products, this graph, the scale is actually in the single millions. So remember, the previous one was in the hundreds of millions. So this is the products that have abuse deterrent labeling, and you can see that the blue line, this is OxyContin. This was the first one to receive such labeling, and it occupies the majority of this market. You can see that the other marketed products right along that lower x-axis, so they have not had as much uptake. And there are about 6 products that have not yet been marketed, even though they've been approved. So they have not really been uptaken. They do not take up a majority of the opioid market. So in our guidance to industry, this is the goal of the studies we've asked them to undertake post-marketing, is to actually try to determine whether their products are associated with meaningful reductions. That's a key term in abuse, misuse, and the related clinical outcomes such as addiction, overdose, and death. So this is not an easy task. We've not been able to set a particular bar or a number because the landscape is constantly changing, and we worry that setting any kind of an arbitrary bar would simply be outdated. So meaningful reduction becomes a very dynamic and changing type of phrase. So what we have laid out in this guidance, we try to give our best thinking to direct industry to do formal studies. These are hypothesis driven studies to look at meaningful measures of abuse in order to actually demonstrate that a particular product has changed abuse. These products, it has to be able to differentiate the actual product that's being abused and also the route of abuse, remembering that these are not necessarily designed to deter all abuse, but are specific to route, so that has to be available. We've asked them to focus on large or national or at least large geographically diverse types of populations, and to make these studies sufficiently powered to examine trends. That's just basic science. But as you saw from the earlier graph, that can be challenging if your market share is not very large. And then we've also encouraged companies to submit what we call supportive information. This is anecdotal or qualitative data that can be very, very useful, but may not rise to the level of hypothesis-driven study, but can complement our understanding and help us to interpret the formal studies more meaningfully. We've had to modify our approach a bit, again, because of the limited uptake. So rather than direct companies to go out and do studies that may not be large enough or statistically powered enough to be able to provide meaningful results, we've asked them to break it into 2 phases, to do a phase 1 study where you're really looking at feasibility and describing what's seen after the product is approved and marketed. And then the second part, that once we both mutually agree we're at a point where a meaningful study is possible, then we move into hypothesis-driven effort, trying to save resources and do things that make sense. So why is this important? If we've got labeling in there that says that we expect them to deter abuse based on controlled conditions pre-marketing, why is it so important to do these post-market studies? Well, the labeling of a product and to have such a claim about post-marketing ability to deter abuse is a very big deal. The labeling is a legal document and it carries a lot of weight. We require high-quality studies with scientific rigor to go into labeling to support a labeling claim. And oftentimes you see that in the form of clinical trials that are done to approve use for an indication. When these submissions come in, these folks that have introduced themselves to you lead the teams that dig into these data. These data are reviewed in depth, and when possible, we even redo the analyses, much like is seen in the clinical trial setting. And whenever we get one of these studies, these submissions for labeling claim, they come to a public discussion, typically an advisory committee meeting, where we share these results with external experts and get feedback before making decisions. So the goal of labeling is really to provide informative and scientifically accurate information to prescribers and to patients. So that's why right now none of these products have post-marketing information in their label, and part of why we're here to talk today. So why is that? What are the challenges? Why isn't this something that's more straightforward to do? Well, some of us who've been in drug safety for a very long time realize that abuse is a very, very different issue than many of the traditional drug safety issues we deal with. I've been doing drug safety for longer than I care to say, and usually the safety outcomes happen in the patients who take the product. Abuse is not like that. It can happen in the patient. It can also happen in others. It can happen in family members. It can happen in anyone. But it could be tied to the prescription for a particular patient. The traditional data sources we often use to study drug safety outcomes, we often use insurance administrative claims data. We often use electronic medical records. These don't work as well because many times the outcomes of abuse are not captured. And these are covert behaviors that people who have substance use disorder don't always share with their physicians. Their physicians may not be aware at all. And then the outcomes, this may not land you in your doctor's office or in a hospital. It could also land you in a morgue. It could land you in jail. So there's a lot of different features to this that make it very difficult to study. And have a very simple graphic to kind of show that, the complexity here. On the left side of the screen, we're trying to illustrate that there's a lot of different ways as a drug is manufactured, distributed, and prescribed, how it can end up with a patient, but it can also end up being diverted and into other hands along that pathway. The result of drug diversion can end up as misuse, abuse, addiction, overdose, and death. Those are the outcomes in the center that we worry about a lot. But also, a patient can receive this, and a patient can end up using a drug inappropriately and experience any of those outcomes. Or a patient could use a drug as prescribed and still end up with many of these outcomes. So there's many pathways to get to these outcomes of concern. On the right hand, we've tried to link how do we study these outcomes in the kinds of data that exist. So you can see sometimes these kinds of outcomes will end up, we could capture them in population-based surveys or healthcare data systems, or in mortality records. And on the far right are all the different ways. There's no one-to-one alignment here in terms of what we can learn about these outcomes for the kinds of data that are out there or that we're trying to build. So it becomes a very complicated picture of how to look at these outcomes and then piece them all together. So many of these studies are using what we call an ecologic model, which is basically doing a pre-post analysis to look at what was going on with regard to the outcomes of interest, like abuse, prior to an ADF product being marketed, and then after. And as we know as scientists, these designs are fraught with challenges. The goal is to try to do those studies and end up with a result where we understand a change in abuse that we're able to attribute to the introduction of the product. And this can be very challenging because there's a whole lot of other things going on right now around opioids, a lot of efforts to change things. So how do we zoom in on the effect of one particular intervention? Again, my colleagues will go into a lot more detail in the specific sessions today, but just to tee up, we don't have a nationally representative database that allows us to look at formulation of product and route of abuse and to understand at a national level whether a product has actually had an impact. So we've directed industry, and we ourselves have tried what we think of as a mosaic approach, or touching the elephant in different spots, to try to see, can we piece enough together from different kinds of studies, different types of data, to come up with a picture that looks at least consistent. And the currently available data sources that we're seeing being used for this work have a fair number of limitations, which can really make it difficult for us to interpret what we're seeing. So how does that bring us to today? And why did we all invite you here? We felt industry and FDA have been talking together for a number of years around these post-marketing required studies, trying to scratch our heads and figure out how to do this. We thought it was time to have an open scientific discussion. So this is a little bit of a different kind of meeting. This is not an advisory committee meeting. What we tried to do is to invite a very diverse group of scientific experts. So we have folks here who have been studying abuse of prescription opioids or heroin or other types of drugs that can be abused for many years. They've used some of the data sources that we've been seeing in the submissions. They've also used other data, so we've asked you to come. We also have folks here who have been conducting national surveillance or designing national systems for data collection for a long time to study all kinds of other public health problems. We've asked you to come. We've got folks here who have been working with data sources that are either out there or soon to be out there or just now out there that may be helpful in this space, but we don't know if anybody's thought about it, so we've invited you to come. We've invited folks who are experts in survey methodology and projection science to try to understand how do we best draw samples that are meaningful and then take those samples up and project them to reflect national experience. We've also invited some traditional folks who've been working in traditional drug safety and pharmacoepidemiology for a long time to try to pick their brains to see what you think. And then we have the folks who actually have experience of trying to figure out the scientific rigor that's needed for regulatory decision making, and that's the folks here. That's hopefully us, who've done this for other issues and now have to try to figure out how to get there for this issue. So our goal is not to solve this problem today. Our goal is to start a conversation and to bring these various disciplines together in one conversation to talk about how can we do this better? How can we do better with what we have? And how can we do better in the future to get better data and better methods? So here's the overall plan. Today, we're going to focus on the data sources. And again, we're not talking about specific names of data sources. We're talking about types of data sources. We're going to talk about what can we do with the resources we have, because we're all very applied, as many of you are as well. We have to determine what we can do with what we have available to us. How can we look at the data and methods we have, and what are things that we could do, ways we could think about them, analyses we could try that would help us to interpret them better. Tomorrow is more of our brainstorming session of, okay, now that we understand what we've got now, how could we do better? Are there new data we could collect? Are there new linkages we could think about? So today, what we've done is we've set this up into 4 sessions. These first 3 sessions, we'll talk, in the first session, we're going to talk about the resources themselves and the kinds of data that are available. The second session, we'll talk about some of the sampling concerns, some of the metrics we've seen being used and what denominators. And then the third session is very challenging of how do we deal with figuring out how to make causal inferences and how to control for confounding of all the other things going on. And then the last session, session 4, Dr. Levinson and I will try to tie together what we've heard in sessions 1, 2, and 3 and try to put forward some themes we've heard to get some consensus on pathways forward. Tomorrow we'll switch gears and talk about, again, potential for the future. So we're going to talk about national surveys, perhaps modifying the ones we have or thinking about new ones. We'll talk about different designs to go beyond, maybe in addition to ecologic designs, maybe we could think about the potential for following patients over time and actually collecting our exposures and outcomes in the same patients. And then leveraging other systems. Can we link data together to fill some of the gaps we see? Are there benchmarking techniques we could use to help further our understanding of how to interpret results out of particular data resources? And again, Dr. Levinson and I will try to tie that together and feed a discussion that kind of defines pathways forward. So the format for each session is going to work like this. Again, this is not an advisory committee, so this is a scientific workshop. Our goal is not, we're not really asking you for advice. We're not asking you for voting on particular questions. What we're trying to foster here is a real scientific discussion for some things for us to think about. So each of the sessions will be chaired by an FDA epidemiologist and statistician. They've partnered up. They will begin the discussion by providing a 15-minute overview. They'll try to take some of the things you saw in the issue paper and drill them down a little bit, give you some examples, actually help you see exactly the kinds of things we really want to discuss. Then they're going to moderate a session with the panel discussion for about an hour, where we want to hear from folks as much as we can about ideas, things you've been thinking about that would fit under that topic. Now, recognize we have artificially divided. All of these topics are connected. So we're going to try the best we can to stay on topic for each session, but we know that they tend to relate to each other, so that's okay. And then at the end of each session, we will have an opportunity for comments from our audience. And this is a little different. I know in the leading up to the meeting, many people weren't understanding at an advisory committee where decisions, recommendations are being made, stakeholders can sign up and give even formal presentations. That's not what this is about today. Today is about allowing members of our audience to be able to chime in to the scientific discussion if they would like to. So there won't be formal presentations, but perhaps comments. We have such an esteemed panel of experts here, but there's lots of experts out there that we couldn't invite to sit on our panel. So if folks have thoughts that would be relevant, that should be considered, that again could tee up further discussion, we'd love to hear it. In the interest of time, the way we're going to do this is at the end of each session, as we have and move into our 15 minutes of audience participation, we ask that people line up at the microphones. There's one on either side. And we'll go through as many folks as we can. We're going to limit your remarks to 3 minutes, and we'll have the familiar green, yellow, and red light just to help us stay on track. But it doesn't mean we don't want to hear. If you have comments that won't fit in 3 minutes, don't worry, we have a docket open for this meeting, and it will stay open until September 11th. And we encourage you, send us slide decks, send us articles, send us your thoughts, send us books, whatever you think would be helping us. We plan to pour through that docket and look through that more detailed information. So what do we see as the output here? Are we just basically just going to talk and then check the box? No. We really want to use this information in several ways. Most immediately, as I mentioned, we continue to support and encourage the development of these products. We talk to our colleagues in industry regularly about their post-market studies, and we can take ideas we hear here and put them right back into those conversations and to help improve the studies as they're ongoing and as we try to get these studies done efficiently. And as we update and revise our guidance to industry, there's another place in the shorter term that we can put these kinds of ideas and comments to push the science forward. In a more immediate term, we at FDA in this past year have established contracts with a number of the providers who actually have a lot of the data that industry is also working with. So there may be certain concepts or ideas that it might make sense for FDA to support through those contracts. And again, those mechanisms are in place, and we could apply funding to those and again, actually implement some ideas if we hear things today that lend themselves to that. We're also, a number of our panelists here are our federal partners in initiatives that we are working on to build new systems to look at emergency room admissions and also be looking at improving death data. So as we work with our colleagues, if there are ideas that come out of today's and tomorrow's meetings, we can feed those into those efforts to improve those as those are ongoing as we speak. And finally, we just initiated a new project under the CIRCE program. The CIRCE is a grant program with FDA with different centers of excellence in regulatory science and innovation. One of our newest CERC sites is Yale and the Mayo Clinic. It's a partnership. We just initiated a project with them where they're going to try to link together data in the state of Connecticut. Again, disparate data, medical data, law enforcement data, death data, and try to see in that microcosm whether they could come up with meaningful linkages that might enable further look at such problems. If we come up with ideas that lend themselves, I'm sure they're aware of this meeting, although they could not attend, and would be happy to implement ideas that we may come up with. And longer term, we have what's called a broad agency announcement. It might be the best kept secret on our website, I'm not sure. But we actually put forward, in effect, what's a research agenda. And improving our ability to study abuse deterrent formulations is on that. And so if folks have ideas, FDA can entertain research proposals, and provided we have funding. But the commissioner was here, so he could help with that. There's a possibility long term that if good ideas could get funded through FDA through that mechanism. And also, I attended a meeting just a few weeks ago, and Dr. Jones is here from HHS. HHS has a new initiative where they're getting stakeholder input to try to improve our data infrastructure in this area. So again, some of these ideas that are good ones could end up with HHS funding long term. It's a possibility. So those are my remarks. And now I'm going to turn it over. We're going to start our first session right away. We'll have our break after this session. I'm going to turn it over to Dr. Cynthia Cornegay, who is our team leader for the epidemiology drug abuse team. She and Dr. Hannah Lee from biostatistics will lead our first session on data resources.